Wanted. Well, where is it? There we go. Okay, going to continue our discussion. We've kind of got through the classifications in the DSM-5, and so now we're talking about treatments. Yesterday we talked about therapeutic treatments, but certainly there are also medicinal treatments, and that's kind of what I want to focus on today, are some of the more common medicinal treatments, maybe a little bit of history of the medicinal treatments used in psychology. So we usually think of medicine as intended to cure specific physical symptoms, painkillers to help a headache, antibiotics to cure an infection like strep throat. So how can drugs be designed to affect the mind, achieving specific results like making someone less depressed or getting rid of hallucinations? Like many medicines, the earliest kinds of psychiatric medications were discovered largely by accident. The first antidepressants were actually intended as treatments for tuberculosis. The first antipsychotics were developed as anesthetics to use during surgery. And these medications were found to improve mental functioning by changing brain chemistry in a variety of ways. In general, what they do is they change levels of neurotransmitters in the brain. Neurotransmitters, and you might remember this from our second unit, biological psychology, are merely chemicals in the brain that allow brain cells called neurons to communicate with each other. Now, psychologists have noticed that the amounts of certain neurotransmitters in the brains of people with certain disorders are different than in healthy people's brains, leading to the development of drugs that aim to correct these imbalances. Antidepressants change the levels of the neurotransmitters norepinephrine and serotonin, which affect emotion and mood. And there are three basic kinds of antidepressants called MAOIs. You may have seen commercials for medicine. If you are taking an MAOI, that's what this is, a monoamine oxidase inhibitor. Tricyclics and SSRIs, which are selective serotonin reuptake inhibitors. And they all function a little differently. MAOIs and tricyclics both raise norepinephrine and serotonin levels. SSRIs raise only the levels of serotonin in the brain. And this creates fewer side effects than MAOIs or tricyclics, though it does increase sexual side effects like lack of desire and erectile dysfunction. MAOIs have the worst side effects, which is why scientists kept working to make the newer kinds of antidepressants. People who take them must be very careful to avoid foods that contain the chemical tyramine. And can you guess what kind of foods contain tyramine? Yeah, all the good kinds, actually. Beer, cheeses, cured meats. And if a person messes up and eats these foods anyway, it can produce a fatal interaction with the MAOI. And these drugs are usually only recommended to people whose bodies can't tolerate the newer antidepressants. So while antidepressants work primarily on norepinephrine and serotonin, antipsychotics work by reducing the activity of a third neurotransmitter called dopamine. Dopamine is the neurotransmitter that regulates pleasure-seeking behavior. And it's been said in scientific circles for decades that if they could find a way to recreate dopamine in its natural state artificially and market it, it would be the most addictive drug on the market. But you know that rush you get when you get an unexpected reward? Maybe you win at the slot machine, or your boss tells you she's decided to give you a bonus. You feel great because your dopamine levels have spiked. But consistently high levels of dopamine can make you really sensitive to excess stimulation. And in the case of schizophrenics, this can cause hallucinations and delusions, known as the positive symptoms of schizophrenia, you might recall. Most antipsychotics have little effect on the negative symptoms of schizophrenia, like blunted emotions and loss of pleasure. But a new generation of drugs called atypical antipsychotics has been shown to have some effect. All antipsychotics can cause side effects like drowsiness, tremors, and coordination issues. There's also a very rare nasty side effect called tardive dyskinesia, which is a permanent neurological condition that causes involuntary movements. And this condition persists even after treatment with antipsychotics stopped. Bipolar disorder is most commonly treated with another type of psychiatric medication called lithium. And if that sounds familiar from chemistry, you're right. It's an element on the periodic table. And when it's used to treat psychological disorder, it's given in the form of a salt or a kind of chemical compound that includes the element. It's also the element you'll find in many of the rechargeable batteries in today's electronics. And though it is still an effective mood stabilizer, the way it works in the brain is still a little bit unclear. Treatment with lithium also requires careful monitoring. Since the active dose is only slightly less than the toxic dose by milliliters, it's very easy to overdose on this. And most medications have a much larger gap between these amounts, which makes accidental overdoses less common. Now, lithium has a long history of use as medication. It's believed that the ancient Greeks and Romans used spring water containing lithium to treat manic and depressive disorders. In the early 20th century, lithium was an ingredient in a beverage that's still consumed today, but no longer contains lithium, and then marketed as a hangover cure. And there's no lithium in it anymore, like I said, but the drink is, have you guessed it yet? 7-Up. So we've got over 3 major classes of drugs for 3 disorders: antidepressants for major depression, antipsychotics for schizophrenia, and lithium for bipolar disorders. And these all work by altering brain chemistry, though in the case of lithium, the exact mechanism is unknown. These drugs can be really helpful to some patients, though psychologists do worry about prescribing them without careful consideration or as a substitute for talk therapy. And since many of the drugs do not keep working after a patient stops treatment, many patients take them for a long, long time, and such long-term side effects aren't always known. Given these problems, psychiatric medication should be seen as simply one type of therapy, likely to be used alongside with other types, and not a be-all and end-all treatment for psychological disorders. Now, before psychiatric drugs were developed, psychiatrists sometimes used other biological methods to try to cure or improve their patients' mental health. And therapists understood that changing the body could change the mind, but they didn't have reliable ways of determining targeted biological treatments. Most of these treatments are either no longer used today or are used as last resort options for severe conditions. And these psychiatric methods used in the past seem crude compared to today's treatments. But it's worth having at least a basic knowledge of the origin of biological treatments to gain perspective on current treatments and to think about the ethical issues that surround many of these methods. After years of working only with talk therapy approaches based on the teachings of Freud, psychiatrists were eager to have options for treating patients that were distinctly medical and could use a more biological, mechanistic approach to working with people with disorders. And these biological treatments seemed at first much more cut and dry than talking about feelings. However, many medically based treatments were largely ineffective and often cruel, but were pursued often because doctors felt like they were really doing something for their patients rather than just talking to them or putting them in a medical institution to live out their days. Electroconvulsive therapy, abbreviated ECT, is one of these, and it became popular in the 1940s as a treatment for non-responsive patients of many psychological disorders, including depression and schizophrenia. Technicians used electric shocks to give patients seizures that were intended to help them recover. And seizure treatments have been used before, but it required giving patients certain drugs that were expensive and sometimes caused unpredictable reactions. ECT gained notoriety in the 1970s due to a high-profile negative portrayals in movies like One Flew Over the Cuckoo's Nest. And actually, one of the Kennedy sisters suffered from a mental disorder, and they used electroconvulsive therapy on her and pretty much left her mentally disabled the rest of her life. And so in the 70s, some of this comes to light and also gives it kind of a bad name. The poet Sylvia Plath described ECT as she was a patient of it. By the roots of my hair, some god got hold of me. I sizzled in his blue volts like a desert prophet. And you might be surprised after hearing such a scary, painful sounding description to know that ECT is still used today in cases of severe depression. And though there are mainly people who feel ECT affected them negatively, others report that the treatment really did help them when their modern antidepressants failed. A common side effect to ECT is memory loss, and because of this, patients are rarely forced to undergo the treatment and are encouraged to weigh their decision carefully. For some, Some memory loss, it's worth no longer feeling depressed. For others, this trade-off is unacceptable. Author Ernest Hemingway complained of the treatment. Well, what is the sense of ruining my head and erasing my memory, which is my capital, and putting me out of business? It was a brilliant cure, but we lost the patient. For someone who wrote fiction for a living, loss of memory was worse than depression. Another kind of shock therapy called insulin shock therapy was used to treat schizophrenia between the 1930s and the 1950s. Patients would receive doses of insulin, a hormone which you may associate with diabetics, and the dose would be high enough to put them into a coma. Doctors would carefully monitor the patient's comas, then eventually revive them. And though some studies showed that it helped, usually the patients selected for the treatment were those with the best chances of getting better anyway. Later, doctors found that insulin itself didn't seem to do anything. Patients who were put into comas by other means had similar results. Insulin treatment had lots of nasty side effects, including massive weight gain, restlessness, and discomfort between treatments. And it fell out of mainstream use by the 1950s and is no longer practiced today. A third kind of biological treatment is known as psychosurgery, or the practice of physically altering the human brain in order to bring about psychological results. My son, who suffers from severe seizure disorders, right now is being considered for this type of psychosurgery to help control the seizures. And this is an extreme treatment. Imagine if a scrape on your leg were infected, and after trying lots of things to cure you, doctors eventually just decided to amputate it. Psychosurgery is an attempt to remove or disable a sick part of the brain so that overall mental health is improved. The most well-known type of psychosurgery is the controversial lobotomy, in which the frontal lobes of the brain are removed in an effort to control the violent and unpredictable symptoms of the severely mentally ill. The procedure typically left patients much more docile than before, but without much of their original personality or functioning. Matter of fact, I'd mentioned the electroconvulsive therapy applied to one of the Kennedy sisters. She ended up going through a lobotomy after that was shown to not be as effective and harmful as they would have liked. Arguments against lobotomies grew after it was graphically portrayed as punishment for a rebellious psychiatric patient in One Flew Over the Cuckoo's Nest. The movie won a couple of Academy Awards, starring Jack Nicholson, made infamous the character of Nurse Ratched. Lobotomies were largely stopped by the 1970s, but other types of psychosurgery are still performed, although rarely. If other treatments have been ineffective, some surgeons, with patients' consent, will target specific brain areas in order to help regulate their emotions. If you're sick and you have a sore throat, it's fairly easy to tell if a particular treatment has helped your throat stop hurting. If you take antibiotics and you feel better, there's a little debate about whether a treatment was effective or not. Even with something more complex like cancer, there are concrete measures that can be used to determine whether a treatment is working. A tumor might shrink, or the cancer might stop spreading. But with psychological disorders, such as clear measures are often unavailable. In some cases, improvement might be obvious. For example, if a woman who was unemployed due to severe depression was able to get a job after attending therapy sessions for a while, therapy could be judged as effective in her case, at least in relation to one symptom of her illness. In other cases, even determining whether someone has a mental illness in the first place is difficult. And you can imagine then how difficult it can be in some cases to tell if a treatment is actually working. There are three main ways in which treatment effectiveness is measured: the patient's own impression of wellness, the therapist's impression, and some controlled research studies. And I'm sure, based on what we've talked about in the past, that you can see where the patient's own impression or even the therapist's impression would have issues. And while controlled research studies are better, even they have some built-in biases, which makes it very difficult for psychologists to really understand objectively whether or not the treatment they've prescribed is actually working. So note that in the realm of physical medicine, the first two methods would be largely irrelevant. A doctor wouldn't simply offer an opinion on whether the patient was better. Then she'd show real concrete evidence of it. But in the realm of psychology, these methods can be valuable, though flawed, tools for evaluating treatment effectiveness. Obviously, as a patient feels better, that's great. So in one sense, a patient's impressions are extremely important. The goal of therapy is, after all, to restore her to mental and emotional well-being. But for the purposes of determining which treatments are most effective in which situations, there are several problems with the patient's own impressions of her progress. The first is simply that people tend to distress, or the first is simply that people in distress tend to get better. There's only so low most people can go before they plateau, and then the only place to go from there is up. And this is known as regression to the mean or average. And it's when people have a tendency to move toward an average level of functioning or happiness from whatever state they are in. If you're really happy, you're most likely to get sadder. And if you're really sad, you're most likely to get happier. People spend most of their time feeling average. So moods that are above or below average are likely to return to this average. And since people usually enter treatment because they're feeling especially bad, they're likely to get better over time, not because of anything the therapist is doing, but simply because they're regressing to the mean. Secondly, people in therapy expect to get better. That's why they're going to see a therapist. For a quick summary, imagine you have a headache. What do you usually do to fix it? Let's say you take aspirin or some other painkiller, and usually the headache goes away. You expect that when you take aspirin, your head will feel better. Now, let's say your friend, playing a practical joke on you, secretly replaces your aspirin with a similar looking sugar pill. The placebo effect predicts that when you take these sugar pills for your headache, you will still feel at least a little better because you expect to. Some of the effect of the painkillers that you think you'll get better when you take one. And this is especially true of therapy's effect on mental illness, since the symptoms are often much more subjective than a headache to begin with. If patients expect to get better, they probably will, at least in some ways. On a related note, patients sometimes feel like they should be getting better as a way of justifying the effort involved in seeking treatment, going to see the therapist, paying money for the sessions or for drugs. And it would be difficult to put in this kind of effort while thinking it was all worthless. And therefore, some patients decide to believe in treatment. Therapist evaluations of patients are subject to all the same problems as patients' evaluations. They too may mistake regression to the mean for positive effects of treatment. They also rely on patient testimony to a certain extent, which may be influenced by the placebo effect or by the justification of effort. Additionally, when therapy is finished, the therapist may continue to hear from patients who are doing well, but not from patients who are dissatisfied, because therapists are reminded only of the positive results. They overestimate how often their patients actually have positive results. And this is known as the availability heuristic. People who are dissatisfied don't come back and continually tell you how dissatisfied and how much it didn't help them. They usually just won't come back. So all that's available to you are patients who have done well. That concludes our lecture for today. Did you guys have any questions regarding this? Okay, then, well, enjoy your weekend, and I will see you back here Tuesday.